Hello, my name is Amandeep Gill. I'm CEO of a new global platform called the International Digital Health and Artificial Intelligence Research Collaborative, or IDARE. This platform aims to harness the digital transformation for universal health coverage. Our mission is the collaborative research and development of health-related digital technologies and platforms with a particular focus on networks, needs, and opportunities in low and middle-income countries. One way to visualize IDARE is to think of a distributed CERN for digital health, pooling talent and resources, treating problems that no single institution or country could have the resources or interest for, and producing and maintaining public goods through open science and R&D collaboration. I'll be speaking to you today about AI governance. Why does governance of AI matter? What purpose should we assign it as societies? How should we approach it? And what could be a model framework for pursuing AI governance in the health domain? Before we move to abstraction, let me bring a couple of concrete examples to illustrate why we should care about this topic. Some time back, automatic faucets ran into a problem. If you had darker skin and you put your hands before it, often they didn't work that well. If you had fairer skin, they worked perfectly well. And the reason was that the sensors had been trained with a limited data set of people with fair skin. It's not that these developers were biased, they were simply blind to the narrowness, the lack of diversity of their data set. And this can be an annoyance, but in another context, this could be deadly. Think about pulse oximeters, so often used today to diagnose deterioration in conditions of COVID-19 patients. They're likely to misdiagnose the level of oxygen in your blood 3 times if you have darker skin. So this has consequences in the real world. Another set of examples I want to bring to our discussion is around the 3 M's of data: missing data, the misuse of data, and the misuse of data. A lot of people buy medicines at pharmacies, and pharmacies have loads of what is called supply chain data. Now, this has valuable insights hidden in it about drug reactions, for example. However, because of privacy concerns, because of the potential for misuse, we are not able to use this data. So the lack of governance around privacy hinders us from making good use of this data. In complete blood count machines, there is a lot of information about what a complete hemogram tells you about a person's health, but most of it is not used. Again, because of lack of governance, lack of regulatory facilitation, and we miss insights on, for example, the emergence of pandemics. In some cases, we simply do not have the information. So it's neither a problem of misuse nor a problem of misuse. It's simply missing data. And I have shown you an example of the missing data on disability faced by younger people when it comes to COVID-19. Now, having looked at these concrete examples, let's ask ourselves, what is the purpose of governance? So if we are agreed that governance is important, under what umbrella should we place it? And I submit to you that the purpose of governance is to create a digital common space with both guardrails and common rails. These common rails are necessary to scale innovation, make the system inclusive for young entrepreneurs, researchers, and startups. And the guardrails are there to ensure there is no misuse and no one gets left behind. As we saw with the report of the UNSG's high-level panel on digital cooperation, which I had the privilege of serving, there is also emerging interest in a global digital commons approach to spread the benefits of digital technologies more widely and prevent another tragedy of the commons through misuse. So apart from promoting the SDGs and addressing social harm, a digital commons architecture can create dialogue on emerging issues and communicate evidence, use cases, and problems. thus making discussion on governance more factful. Now let's move on to the how of governance. The first aspect of how that I would like to highlight is tiered governance. So here, national and regional regulation, such as that embedded in the EU GDPR, have to be buttressed by international norms and industry standards and arrangements for informed user choices. So governance interventions at these macro, meso, and micro levels have to be mutually reinforcing to make the digital system safe, inclusive, and publicly beneficial. In this manner, we can also tailor data and AI interventions to specific contexts, such as the sharing of disease-specific data during a pandemic and helping individuals and collective agents to understand the health implications of their data-related decisions. This is also a way to make governance multi-stakeholder or SMART across governments, private sector, and civil society. Now, the second aspect of how that I'd like to highlight is a diverse governance toolbox with both soft and hard regulatory tools. At the soft end of the spectrum, values, for instance, can guide policy making and implementation. They can channel international norms across nations and be more flexibly deployed across cultures and borders. They can also, importantly, extend governance into the early and ambiguous parts of the technology development cycle. The third aspect of the how is an end-to-end or a life cycle approach. The UK Competition and Markets Authority, for example, has highlighted this challenge for regulators in a recent paper on what it calls algorithmic systems, a larger intersection of algorithms, data, models, processes, objectives, and how people interact and use these systems. Regulators need to be trained and need to develop a set of techniques to audit the systems on an ongoing basis, assess harms, and remedy them without necessarily having access to the code and the training data sets. So let me pause here and summarize what we've discussed so far. AI governance has to be under a public commons umbrella. It has to be collaborative, distributed and tiered, values-based, and end-to-end, from context to data to AI to impact assessments and redressal. I would now conclude my presentation with a brief description of a concrete mechanism for governance of health AI that we have developed at IDEA. For the mechanism to be applicable across different tiers of use and geographies, it cannot be in the form of a single regulatory standard. Instead, it is devised as a community-facing governance innovations exchange anchored in a robust set of principles, mechanisms, and norms, and thus can be applied globally to the data and AI tools proposed to be used for health research, healthcare, and health promotion through a network of collaborating institutions based in different national jurisdictions. The mechanism facilitates the work of these institutions with distributed data sets and confederated learning, while allowing for exchange of best practices and governance innovations and tools with each other. So here you see these three different aspects of this mechanism. Now, this helps us realize the vision for IDEA as a distributed CERN for digital health and AI research, in which a network of IDEA hubs across the globe is united for the development of digital public goods for health, while retaining their data sovereignty and their self-rule. Together, they enable R&D by developing shared problem definitions, research design, and data models, catalyze investments into infrastructure and human capacity, and help promote inclusiveness in knowledge production. We've had this look at AI governance from a conceptual perspective, and now we will move to two practical use cases in which we can apply this framework. So to have a look at those use cases, I'm joined now by two of my colleagues, Dr. Pei-Ling Yap, Chief Scientist, and Dr. Mehdi Snen, the Research and Development Director for IDEA. Welcome, Pei-Ling. Welcome, Mehdi. The two use cases that we've picked up for discussion today are the antimicrobial resistance work of IDER, AMR work of IDER, and the work related to benchmarking of digital health solutions, in particular electronic patient-reported outcome metrics, or EPROMs. These are two of our strategic projects for 2021, and they offer us an excellent opportunity to test the AI governance framework that I have previously presented to you. So let me start with you, Pei-Ling. If you can tell us a little bit about why the AMR work is important and how does AI help there?
Mm-hmm. Thanks a lot, Amandeep. And sure, yes. AMR, antimicrobial resistance, basically causes 700 deaths per year globally. And if left uncontrolled, this is estimated to go up to 10 million deaths in 2050. And we know that beside drug-resistant infections, AMR will also impact on routine healthcare interventions such as surgery, organ transplants, and etc. So AMR itself is like a silent pandemic in the making. Therefore, it's definitely a true global health challenge that IDER is keen to take on. So how AI can help, and it's really across the spectrum, right? Here we see that, first of all, AI can really help to transform surveillance data from currently being informational to analytical and predictive. So this really allows for policymakers in the future to predict areas of emerging resistance and respond in a timely manner. Second, it is also very critical, it can play a very critical role for clinicians in terms of clinical management of infections, be it prediction of drug-resistant infections, and also allowing for a complex matrix of data, host immune system, previous antibiotic consumption to be analyzed prior to the prescription of the right and appropriate antibiotics. And thirdly, AI can help on the patient end as well. And this is really to increase awareness for AMR, so behavior changes, and also improve compliance among patients when it comes to consuming antibiotics. Right. So, yeah.
Now, in this, what is the biggest challenge? So when you are working across geographies, when you are working across the clinical domain and the community domain, so what is the challenge in bringing data sets together?
Yeah, so the first challenge is really about data interoperability, right? Including semantic considerations, privacy and security, then all these factors will be a huge challenge. And therefore, we do need a common framework for the data sets. And so in this project, what we sort of seek to start off with under the first phase of our project is to really build a common representation across structured data sets from India, Singapore, and potentially Kenya. And at the same time, this common information architecture will also support the acquisition, analysis, and the use of unstructured data using AI-based techniques. And the second challenge here, so by building this common representation, we can actually then start to use, distributed data sets across geographies without them leaving their borders to build the AI prediction models and the clinical decision support systems that we want to build. And the second challenge will be that the interventions have to be context and cultural specific in order to be effective. And therefore, we also have planned a phase in our project, which is also at the beginning, to do what we call a formative assessment. So using mixed methodologies, so using both qualitative and quantitative methodologies, we want to first create that kind of context for the algorithms to work. So we want to understand how clinicians make their decisions when prescribing antibiotics. We want to understand the role of other healthcare professionals in influencing the clinician's decision to prescribe and for patients to comply to treatment guidelines. And we also want to explore the willingness of clinicians to accept AI-based clinical decisions made by these algorithms. And finally, how we want to sort of overcome this challenge is also to have what we call co-creation workshops. So during the midst of developing the models, we will also conduct these workshops where we explore the most acceptable, sustainable, and scalable interface between the algorithms and the prescribing clinicians, so that we can identify facilitators and barriers for optimal usability, acceptability, and scalability.
So my last question, Pei-Ling, is how does governance come in here? Because you are working in different geographies. So each geography has its own governance framework, its own regulation. So how do you tune this across different contexts for governance?
Yeah. You're right, Amandeep, to say that, different geographies, they do have different policies, regulations, and even information systems, as we have discussed earlier. And so what we have to do is and so what we plan to do in the project is to, first of all, we have to review the currently available guidelines, the global, national, and state action plans, to really understand what are the guidelines for antibiotic prescription and what are the guidelines for data governance. And then at the same time, we have to make sure that the architecture that we, the information architecture that we build will support other related information such as policy, security, and privacy requirements. And the sort of governance framework that you have proposed earlier could come in really handy to allow for that kind of interaction with the stakeholders, to allow for buy-in and trust into the governance of the data.
Thanks a lot, Pei-Ling. And I'd like to move now to Mehdi. Mehdi, you are focusing a lot on infrastructure. So in a sense, the capacity side of the AI equation. So could you describe to us what's the challenge there in terms of the research infrastructures for researchers and innovators?
Sure, thanks, Amandeep. So the major issues we are facing is the variety of existing infrastructures, the very poor intercommunication and exchanges between different existing pieces within the same infrastructures often. So the idea is to build an entire research dedicated infrastructure that can be deployable under different constraints within different geographies, also to establish a bridge of communication between these existing nodes or edges when we talk about AI, to leverage the quantity of data and to enhance the model optimization and the generation of more efficient and more scalable models. In that perspective, knowing the different constraints that we have regarding the data, national health data, how to these rules are making these data sovereignty very tight and very anchored inside of the countries and nations, and often inside of the data owners as hospitals. So the idea behind it is to create a federated model approach based on existing edges of the research infrastructure that only communicate through their results rather than communication about the data they are storing. So what we tend to create with the research infrastructure is to build a fully distributed, but with an entire sovereignty within the border of the data, while we are sharing the knowledge in a seamless manner, in a very easy manner between these different nodes, so we can easily scale up the models that are generated on the local side to make it much more global and to make its reach bigger than on a simple national range. So this is the vision we got. Inside of this vision, we put the patient inside of in the middle. We place the search again in the middle of the village. So the idea behind it, if we are building a research infrastructure for research, for clinical researcher, the output or the outcome of the research infrastructure, defending the models that are built in, should not be simply dedicated for the research, but I also should consider what are the benefits of the patient from this kind of research infrastructure. So our thinking is fully dedicated to the patient. And although we started with this kind of infrastructure as a research infrastructure, we would like to extend it further to get beyond the clinical trials and the clinical research environment to the practitioners' day-to-day operation, so that the patient can be included inside of the value chain of this kind of infrastructure, and that his voice is heard inside of the research infrastructure, and the research is no longer dedicated fully to the willing or for the funding availability or for specific projects, but is customized. The research projects are customized according to the real needs and expressed needs by the patient himself.
Right. So I love this analogy, Mehdi, of the church in the center of the village, how the patient comes to the center of the village.
So till now, the value chain of health is strongly different, is essentially different than other business models if we bring this kind of analogy into that. This is, but the health business is not really a business. The health business is something completely different, where it's about life, it's about health and well-being, it's about severe conditions. So the output or the outcome or the return on investment should be considered completely differently than other kind of usual business where we are selling goods. We do not sell goods there. And for that purpose, the first thing is we should consider what is the patient thinking about what we are offering to him in terms of services, in terms of products, or in terms of help. And then we need to put the patient in the middle of all of our interactions when we are considering all these aspects. And for that purpose, many voices today are calling for the inclusiveness of the patient voice through the patient-reported outcome monitoring, but also through the patient-reported experience monitoring as an essential step to bring back the voice of the people to whom we are providing the service into the cycle of the evaluation. Till now, the EPROM or the PROM was considered essentially for health insurance to validate the efficiency of medical activities and to see if they have to continue the insurance schema of this or other drug or intervention. But rather than that, we should consider that from the patient vision, and we should put the patient in the middle of this consideration and the patient himself as a point of care. What is the EPROM approach taking into that vision? We need firstly to lay out the aspects of different exchanges and different exchanges structures between the patients and the healthcare providers. And for that purpose, we need to consider what we call the unstructured data. Often the patient is not coming using ICD-10 form of exchange of data. This is not formalized exchange at all. It's very natural language. It's very unstructured. It can happen at any moment. And we should be able to handle this quantity and this kind and structure of data at any moment. And this is why we needed to be real-time collected. So once we started thinking about what is the patient opinion, when does it appear, and then how to handle and what kind of knowledge we can extract from that, then we can start thinking about how to create some more unobtrusive collection of data, either based on digital biomarkers, digital interactions, or based on feeling, use of natural language processing, or any of all the existing technical means today that could come up with some concrete results regarding the patient-centric outcome or the patient outcome appreciation. So if we bring back the patient in the middle, we will we believe that we will increase the performance, efficiency, and also the trust between the patient and the health care. But also this could be considered as an essential step to increase the preventive actions to increase the patient adherence and patient literacy when it comes to his own health conditions, because we will bring back this feedback to the patient, and we will be very warned about any signals coming from the patients. Once he is in this kind of monitoring environment, the patient will feel much more comfortable, and we consider that he will be looking more into the different signals, different data we are transmitting to him, so he can interact closely and he can act on his health conditions.
So are you confident that the privacy and security of data can be protected under this approach?
So as often we think about security and privacy as a unique level of how we can secure by these kind of data, or how we can make this data inaccessible. So our vision is these data are belonging to the patient. These data should stick with the patients, and only the patient should be allowed to share that with healthcare providers, clinical trials, researcher, whoever we would like to share with him, once he got some informed decision mechanism that can inform him about the harm, about the dangerosity, or about the actions he is committing. So it's much more about what we are doing today, sharing our personal data. Some of us are aware of it, some others are not aware. How to ensure that this level of awareness is a minimum spread across different clusters of patients, categories of patients, how to adapt this awareness to these different kind of patients, in order to be sure that we have delivered the right message about the awareness to the right patients. And then I consider that he must be fully the owner and the decider about how to share his data.
Thank you so much. Thank you to both of you for sharing those insights. And thank you to all of you who are listening in, watching us, for your patience and for your attention. Take good care. Goodbye.